Hi everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. My email is sreeklpm@gmail.com. I am also the medical author of the two books Focused Neurology and Exam Oriented Clinical Neurology. We are continuing with the series of Prime Neurology lectures. There are 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, one would have acquired a good knowledge of neurology. Right now we are on Prime Neurology Part 21, Epilepsy Part 1, Introduction and Anti-Epileptic Drugs. Epilepsy terminology. We have to know the definitions of seizure, epilepsy and epilepsy syndromes. What is seizure? A seizure is a transient occurrence of signs or symptoms due to abnormal, excessive and synchronous neuronal activity in the brain. Epilepsy. Epilepsy is a condition in which a person has a risk of recurrent seizures due to a chronic underlying process, usually defined as two or more unprovoked seizures. Epilepsy syndromes, in which the clinical and pathologic characteristics are distinctive and suggest a specific underlying etiology. Example, mesial temporal lobe epilepsy syndrome. Pathophysiology. The brain must maintain a continuous balance between excitation and inhibition to function normally. The inhibitory transmitter is GABA. GABA aminobutyric acid is particularly important, acting on ion channels to enhance chloride inflow and reduce the chances of action potential formation. Excitatory amino acids glutamate and aspartate allow influx of sodium and calcium and enhancing the chances of action potential formation. Seizures result from an imbalance between the excitation and inhibition. Intracellular recordings during seizures demonstrate a paroxysmal shift in neuronal membrane potential. Now let's talk about the anti-epileptic drugs. The classification of anti-epileptic drugs according to their mechanism of action. Almost all the anti-epileptic drugs will fall into one of these 6 categories. What are the 6 categories? 1. Sodium channel blockers. 2. Calcium channel blockers. 3. GABA agonists. 4. Glutamate antagonists. 5. Synaptic vesicle protein binding. 5th, drugs acting on potassium channel opener. Sodium channel blockers. The main drugs are Phenytoin, Carbamazepine, oxcarbamazepine, eslicarbazepine, lamotrigine, zonisamide, lacosamide and rufinamide. There are other drugs also. Among the calcium channel blockers, the main drugs are ethosuximide and sodium valproate. Among the GABA agonists, the main drugs are benzodiazepines, phenobarbital, Tiagaban and Vigabatrin. Amongst the glutamate antagonists, the main drugs are perampanel and felbamate. Amongst the drugs acting on the synaptic vesicle protein binding, it is Levetiracetam and Brivaracetam. The potassium channel opener, the drugs acting on the potassium channel openers are reticabin. So if you see these anti-epileptic drugs, either they block the sodium channels or the calcium channels, or they enhance the GABA or decrease the glutamate, or drugs like Levetiracetam act specifically on synaptic vesicle protein binding, or drugs like reticabin act on the potassium channel opener. So almost all the anti-epileptic drugs will be fitting into one of these 6 categories. So now let's see the mechanism of action of anti-epileptic drugs on excitatory and inhibitory synapses. So first let's talk about the excitatory synapse. So you have the propagated action channel here. You can see the propagated action channel. So the sodium starts coming now. There is a sodium channel entry. So drugs like Phenytoin, Carbamazepine, Valproic acid, Phenobarbital, Rufinamide, Lamotrigine, Lacosamide, Topiramate, Zonisamide, Oxcarbamazepine, they are voltage gated sodium channel blockers. So once there is a sodium entry, there is excitatory presynaptic terminal, there is a depolarization, there is a vesicular release. So you have SV2A, so Levetiracetam acts on the SV2A. So then you have the release of potassium. Here the potassium. So topiramate acts on the potassium. You have AMPA and kainate receptors. Here if you see there, you have the subunit of L-type calcium channel. So these drugs gabapentin and pregabalin act on this channel. Then you have the Phenobarbital acting on the NMDA receptor, the potassium and the calcium sodium. This is the postsynaptic neuron. So this is the excitatory synapse. So we have the sodium channel blockers. We have drugs acting on SV2A Levetiracetam. We have drugs acting on L-type calcium channel gabapentin pregabalin. We have drugs acting on the NMDA receptor Phenobarbital. We have drugs acting on the AMPA and kainate receptors topiramate. So here you can see the glutamate. This is the excitatory substance. Now let's see the mechanism of action of antiepileptic drugs acting on the inhibitory synapses. So in the last slide we saw the excitatory synapse. Now we are talking about the inhibitory synapse. You have the glutamate, the excitatory substance, getting converted into the inhibitory substance GABA by glutamic acid decarboxylase. This is the inhibitory presynaptic terminal. So GABA comes here. You have the GABA T. So we have Vigabatrin acting on the GABA T. The GABA succinylcholine, succinic semi-aldehyde glial cell. You have succinic semi-aldehyde coming like this. Your GAT1, the tigabin acts on this. The GABA is released here, which acts on the receptor chloride channel. This is the GABA A. This is a postsynaptic receptor. So the GABA comes here, activates the chloride channel. So we have drugs acting on this GABA chloride channel, that is the benzodiazepine, barbiturates, felbamate, topiramate and zonisamide. So we have antiepileptic drugs acting on excitatory synapses as well as antiepileptic drugs acting on the inhibitory synapses. So it decreases the excitatory substance and increase the inhibitory substance so that the epilepsy is under control. Now let's talk about the individual drugs. Phenobarbital. Phenobarbital is the oldest anti-epileptic drug. It exerts its anti-epileptic action by binding to the GABA A receptor and prolongs the opening of the associated chloride channel, resulting in increased chloride influx. The increase in intracellular chloride results in hyperpolarization of the postsynaptic neuronal membrane, which helps in interrupting the spread of epileptic activity. It's a strong inducer of hepatic P450 enzyme system and thus accelerates the metabolism of the drugs metabolized by the liver, such as oral anticoagulants. A very important concept. Phenytoin, phenobarbital and carbamazepine are strong inducers of hepatic 450 enzyme system, and therefore the drugs which use this enzyme system gets metabolized fast and their action gets limited. The half-life is shortened, whereas drugs like sodium valproate inhibits hepatic 450 enzyme system, and therefore drugs acting this pathway, their action gets prolonged, like lamotrigine. So we have to know this important concept of hepatic 450 enzyme system inducers like phenytoin, phenobarbital and carbamazepine, and hepatic 450 enzyme system inhibitors like sodium valproate. Another drug which neither induces hepatic 450 enzyme system nor inhibits hepatic 450 enzyme system is levetiracetam, and therefore levetiracetam is gaining excellent popularity because it has got no drug-drug interactions, because it is neither a inducer of hepatic 450 enzyme system nor an inhibitor of hepatic 450 enzyme system. So this is a very important concept. Coming to phenobarbital, it has a half-life of 70 to 110 hours, which is the longest of all AEDs and can be given once a day. It has a broad spectrum AED and can be used in status epilepticus. Phenytoin. Phenytoin, it blocks voltage gated sodium channels by stabilizing its inactive state. It produces a voltage and frequency dependent block in channel conductance, thus preventing high frequency repetitive firing which occurs during seizures. Due to its high frequency dependent blockade, it does not block normal action potentials and hence does not have generalized depressing effects on the central nervous system. It's a strong enzyme in uses and has drug interactions with multiple drugs. Another important point about phenytoin is that due to its saturable metabolism, phenytoin follows non-linear kinetics. Unlike other drugs which follow linear kinetics, phenytoin follows non-linear kinetics. What does this mean? Beyond a certain dose, there is a disproportionate increase in the serum levels with incremental doses. Hence, a small increase in dose can cause toxicity. Phenytoin is effective against all types of partial and secondary generalized seizures and status epilepticus. It is not effective against myoclonic and absence seizures and may even aggravate these seizures type. So we have to be careful when you are treating myoclonus and absence seizures. For parenteral use, fosphenytoin is a better choice as it does not cause local reactions, less incidence of hypotension and can be infused more rapidly. Carbamazepine. It acts by frequency dependent blockade of the voltage gated sodium channels. It's an inducer of cytochrome P450 system resulting in significant drug-drug interactions. This is what I've been telling. Another important concept of carbamazepine is that carbamazepine induces its own metabolism known as auto-induction, which results in shorter half-life and lower drug levels over 2 to 4 weeks. It takes about 4 weeks to reach steady state levels. The most important active metabolite of carbamazepine is carbamazepine 1011 epoxide, which is responsible for many of its side effects. Unlike carbamazepine, oxcarbamazepine does not produce epoxide metabolites, which is responsible for the side effects of carbamazepine. The usual starting dose of carbamazepine is 200 milligrams at night, which can be increased by 200 milligrams every week to a maintenance dose of 800 milligrams per day in 2 divided doses. It is the best option for initial monotherapy for focal epilepsy. Valproate. The main advantage of Valproate is that it's a broad spectrum anti-epileptic drug, and therefore when you are not sure of the seizure type, what treatment you have to give, you can safely start Valproate because it acts on almost all types of seizures and it's a broad spectrum anti-epileptic drug. Why it is a broad spectrum anti-epileptic drug? Because it has got multiple actions and has an inhibitory effect on T-type calcium currents, which is useful in absence epilepsy. It is effective against all seizure types including myoclonic seizures. It's a potent enzyme inhibitor and results in increased concentration of other drugs such as lamotrigine. Valproate has the highest potential of teratogenicity among all AEDs and can produce major congenital malformations such as neural tube defects, cardiac malformations and cleft palate. So the main advantage of Valproate is that it's a broad spectrum anti-epileptic drug, but the main disadvantage of anti-epileptic drug is that it has got highest potential of teratogenicity and therefore pregnant ladies with seizures we have to avoid Valproate. The usual starting dose is 200 mg per day, which can be increased by 200 mg every 7 days to a maintenance dose of 1000 mg in 2 divided doses. Intravenous Valproate is also being increasingly used as a second line therapy in status epilepticus. Levetiracetam. The big advantage of levetiracetam is that it neither induces hepatic enzyme system nor inhibits hepatic enzyme system, therefore it has got absolutely no drug-drug interactions, very safe. It can be safely given in pregnant ladies with epilepsy. It can be given safely in elderly patients who have comorbidities. So that is a big advantage of levetiracetam. It binds to the synaptic vesicle protein SV2A and modulates synaptic transmission through alteration of vesicle fusion. SV2A is important for bioavailability of calcium dependent neurotransmitter vesicles. This lack of SV2A causes decrease in action potential dependent neurotransmission. So this is the main advantage. It is neither metabolized by the cytochrome system, nor it induces, nor it inhibits the system, and thus has no drug interactions. It has one of the least teratogenic potentials among all AEDs, and therefore can be safely given in pregnancy with epilepsy. The other drugs which can be given are lamotrigine and oxcarbamazepine. The usual starting dose in adults is 250 milligrams once or twice daily, which can be increased by 250 milligrams every week to a dose of 1500 to 3000 milligrams per day in 2 divided doses. Due to its ease of use, lack of any drug interactions, minimal teratogenic potential, and the lack of major side effects, it is fast becoming as the initial therapy of choice for all types of seizures. Benzodiazepines. They act on the GABA A receptor, increasing the frequency of GABA mediated chloride channel openings. Midazolam, lorazepam and diazepam are used only in the acute management of seizures and status epilepticus due to the rapid development of tolerance because they are 1,4 benzodiazepines. But clobazam, which is a 1,5 benzodiazepine and clonazepam are used for long-term treatment of epilepsy because they are 1,5 benzodiazepine. Clonazepam is especially useful for myoclonic seizures and can be used as an adjuvant therapy in juvenile myoclonic epilepsy. Clobazam can be used for intermittent prophylaxis of febrile seizures. So this is a big advantage for clobazam. Generally, when we start anti-epileptic drugs, it is given on a continuous basis for a long term. But there are certain seizures which occur only in episodes, like febrile seizures, where children get seizures only during the episode of fever, or catamenial epilepsy when women experience seizures only during menstruation or just immediate or post menstruation, or hot water epilepsy when people experience seizures when they take hot water. So only certain period they get seizures. So no need to start an anti-epileptic drug which is given on a continuous basis. In those episodes, in those seizures which occurs episodically, clobazam is very good because clobazam can be given as intermittent prophylaxis for febrile seizures. Lorazepam is the drug of choice as the first anti-epileptic for status epilepticus due to its rapid and sustained anti-epileptic action. So lorazepam is the drug of choice as the first line anti-epileptic for status epilepticus due to its rapid and sustained anti-epileptic action. Intranasal midazolam is very effective for pre-hospital treatment of status epilepticus and can be used as a rescue medicine in patients with seizures clustering. Vigabatrin. The most important and serious side effect is progressive and irreversible constriction of visual fields which can occur in approximately 1/3 of patients. Its main use remains in the initial treatment of infantile spasms, especially in cases with tuberous sclerosis, where it can produce remission in 50 to 70% of patients. Now let's talk about the discontinuation of anti-epileptic drugs. It seems reasonable to attempt withdrawal of therapy after 2 years who meets the following criteria. It seems only reasonable. There are no definitive criteria. It seems reasonable to attempt withdrawal of therapy after 2 years who meets the following criteria. Complete medical control of seizures for 1 to 5 years. Single seizure type with generalized seizures having a better prognosis than focal seizures. Normal neurological examination including intelligence. No family history of epilepsy and normal EEG. So these are the wonderful concepts of anti-epileptic drugs. The other important concepts of clinical neurology, I put it in a book called Exam Oriented Clinical Neurology, written by me, Dr.Sreenivas, published by White Army. This book will be very useful for students appearing for clinical neurology exams, and therefore if interested, this book could be purchased. The other book I wrote is Focused Neurology, written by me, Dr. Sreenivas, published by CBS Publishers and Distributors. This book contains all the essential theoretical aspects of neurology. So this book will be very useful for students appearing for Viva or orals. This book is available online from all leading booksellers including Amazon. So if interested, this book could be purchased online. As I said earlier, there are 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, one would have acquired a good knowledge of neurology. Just now we have finished another episode of Prime Neurology. So if you have liked it, please like, share and subscribe to my YouTube channel Dr. Sreenivas Medical Concepts, which is one of the leading neurology educational YouTube channels, and my FB page Dr. Sreenivas Concepts. Thank you. Bye.